forth, just like I have the job at Dollywood now.
Well, when I first started here, I had a student that he was working double shift at Calhoun's on the river every Sunday night, and then he had a class at 9:30 on Monday morning. And
That's rough.
Oh, it is, and it just cut him a little slack,
Yeah.
because we all get tired, and we're all things are gonna happen. So.
Yeah, I think Wednesday will chronically be my my like tired day because I end up working the third shift job, and then I come in, and then I have kind of like this social obligation with friends every Wednesday. Like we all have the scheduled thing, and so then I end up going back to work the next night, and then have the next class on Thursday.
Right.
So it's like I have a very limited window of sleep both days, and if it gets messed up, I don't sleep.
I know that feeling, I'll tell you, I have not been in a classroom facing live people for almost 3 years. And so, it's fantastic, but I'll tell you that my legs hurt walking around. I'm on my feet for 6 hours straight without a break. I can't see anybody to do that.
Yeah.
Just set. Yeah, it's good for me, but I have to get used to that all over again. So.
Yeah, I know. Like when I picked my my airbrushing job up, it's different from like the janitorial, and like I have both jobs right now. But like the janitorial, you walk around all night long,
Right.
You do stuff, and you don't really stand in one place very long. The airbrush is the opposite. You walk a mile in, and then you stand there all day long and brush.
Oh yeah.
So
Yeah. Oh, I know. Well, see, like last spring, I had one class on the ground with a few people in it, most were Zooming. One class that was completely Zoom. So I would come in here and I would lecture from the podium, but I'd be sitting down. And prior to that, for 2.5 years before that, everything was, from my home office.
yeah, it's crazy. I don't engage very well online, so it's like unless like I really can't make it, I will probably be here in person.
Yeah, I will tell you that last fall I was so tired teaching online, not because I didn't like what I was doing. I just wanted to see.
Yeah, that's the big thing. Like being able to talk to people in person has a big effect.
Oh yeah. You can read people. You can tell. Are you getting it, or am I, right over your head?
Yeah.
That's very important. It's hard. You can't read the group when you're online. At least not very well.
Yeah, you also can't speak very well when you're online either because, most people have the ability to discern noises in an immediate environment. Online, it's all coming from the exact same source, so you can't discern it when there's more than one.
Exactly.
And so like fun little comments that I make or just questions I throw out, normally are extremely disruptive online where they aren't here.
Right. And it's like you say something that that try and make a point, you make a joke about something, and it just, I know exactly what you mean.
Yeah. And it's like, I actually don't make as many jokes that pop into my head.
So, well, I gotta get ready for my next one. So
All right.
have a good weekend. I'll see you next Wednesday.
All right. Sounds good.
Good morning, Dr. Sparrow.
Good morning. How are you?
I'm good. How are you?
Okay.
Do you know Jane Parrish?
Oh yeah.
She's my mom.
Okay. She told me, she warned me that you were going to be in my class. I mean,
Yes.
yes. So
That's me.
yes, I've known your mom for a long time.
I thought you had, but yeah, that's me.
So I'm glad you're here.
Yeah, I'm enjoying it. I hope I don't annoy you with all my questions.
No, I love the questions. Really, I do. So ask away.
Okay. I just feel bad sometimes because I feel like I'm interrupting after.
Oh, no, really, I really do love questions.
We're good, okay. How are you? You got a frozen coffee today, huh? Yeah, I tried. Is it good? Not a fan? I think pumpkin is- Apparently it's better iced. Is it? Well, you had ice in it. Yeah, that's true. That's fine. Wasn't too bad. Okay. You should have been silently going off the sliding door, and there's a guy sitting outside. I like the sliding door that I made my way to the apartments. I walked all the way out to the sliding door. He didn't know it's hard. And I just walked in and saw him. No. Because he thought I was the way he was going in. Solid. I just kind of threw it together, it's so heavy. Like in the back, it doesn't offset, but it's not real, I don't know, so. I tried to do it 3 different times, just wanted to do it. Did you? Yeah, cause like my hair, when it's like, it's a hit or miss, sometimes when it's greasy, it'll go together really nicely, other times it's like, just not today. And today was one of those days. first test is gonna be?
Well, we'll probably finish up endocrine maybe today.
Okay.
So probably a week or so out, maybe next Wednesday,
Next Wednesday.
Yeah.
Okay.
possibly. I'll just see if I get done or not. So.
Okay.
Well, I see we have a big crowd today.
Yeah.
So, okay, we're going to go ahead and get started. Everybody on Zoom should be able to see the slide that says adrenal glands, adrenal medulla. If you don't see it, let me know. And we will get started then. Okay. We had gone through the adrenal cortex the other day and gotten through all three layers of that. So now we're going to move into the medulla, the inner portion of the adrenal glands. The adrenal medulla secretes epinephrine and norepinephrine, mostly epinephrine. It is controlled through not the pituitary gland, not ACTH or anything like that. It's controlled from the hypothalamus. And it is under direct control of the sympathetic nervous system. So when we are exposed to stress, short-term stress, fight or flight environments, we respond by secreting epinephrine from the adrenal medulla. And what will happen here during a fight or flight response, we will release a lot of epinephrine, and we will tell our tell our liver to convert a lot of glycogen to glucose. We will see our blood vessels constrict. We will restrict blood flow to the unessential sort of organs, like during a fight or flight response, you're not going to pay attention to your digestive system or to your skin or to your reproductive system or to your urinary system. You're going to be sending blood to the heart, to the lungs, to the brain, to the muscles so that you can do something. You're going to see a rise in your blood pressure. You're going to see a rise in your heart rate, and you are going to do something. You don't know what you're going to do. There's no guarantee you're going to, as they say, fight or flight. We don't know. Many things that would trigger a natural response to run away have to be overcome. If you're a first responder, if you're dealing with first responders, they're trained to just do the opposite of what their adrenal glands are saying. Hey, run away. So we have fight or flight response. Regardless of this, in a fight or flight response, the surge of epinephrine, we get lots of energy from that surge because we release lots of glucose from the liver. We raise our blood pressure. We raise our heart rate. We breathe faster. We're gonna be powering up our muscles. And this is why when we come down from a fight or flight response, we're very tired. We're exhausted. Many times people are cold. You see people at disaster scenes where they're, in the middle of the summer, they're putting blankets around them because they've gone through some sort of high stress response to the event, whatever it was. And so now they're cold. Their blood pressure's dropping, their heart rate's dropping. The blood supply is moving away from the muscles and the lungs and stuff like that, moving back to the other organs, and they're cold and they're exhausted. The parasympathetic side, the counterpart, the antagonist of the sympathetic side, will inhibit this fight or flight response. Remember from AP1 that the parasympathetic side tends to be our dominant side, of the peripheral nervous system, of the autonomic nervous system. The parasympathetic sides are dominant side. And so we don't generally run around in a high state of fight or flight all the time. We could not sustain it. So now epinephrine and norepinephrine work very similar to one another. Epinephrine is going to cause our blood vessels to dilate. It's trying to increase blood flow to the skeletal muscles and to the heart. Norepinephrine tends to shut down peripheral circulation. The extremities and to the skin and places where we're not really concerned in a fight or flight response. Are we sending enough blood to our skin? Well, we don't care in a fight or flight type environment. So norepinephrine opens up the airway. It opens up the large vessels. Norepinephrine restricts the vessels. So two different responses, two different locations. Vasoconstriction, they're going to tell the smooth muscle around our smaller vessels to constrict. Anytime we're dealing with a fight or flight response, so the response is immediate and very short term. The hormones from the cortex, the aldosterone, the cortisol, even the androgens have much longer term responses. Aldosterone is going to affect your sodium levels in your body again and again and again, to the point that we can control sodium levels by controlling aldosterone and use it to treat hypertension. But that's a long-term effect. The release of the epinephrine and norepinephrine are going to be very short, very brief. Okay. So long-term stress uses the mineralocorticoids and the glucocorticoids. Short-term uses epinephrine and norepinephrine. Okay. Problems, homeostatic issues here. If you are hyposecreting epinephrine, you don't even notice it. We don't necessarily need large amounts of epinephrine in our bodies all the time. And so we will continue to release norepinephrine, for example, to allow our peripheral blood vessels to open and shut, because we're always moving blood around that way. But if we are hyposecreting from the adrenal medulla, we're not going to notice. If we are hypersecreting, that's a completely different story. If we are hypersecreting epinephrine, we are going to have uncontrolled sympathetic nervous responses. In other words, we're going to have uncontrolled fight or flight response. Your patient with hypersecreting epinephrine is going to be hyperglycemic. Because they're going to be dumping lots of glucose into their blood. Epinephrine tells the liver to release lots of glycogen to make glucose. It also tells the pancreas to make glucagon, which works with epinephrine to cause even more glucose to come out. So you're going to have a patient that is hyperglycemic. Their blood glucose levels are way up. Their metabolic rate's going to be very high because during a normal fight or flight response, you release a lot of glucose and you start processing it right away so you can have all that available energy. Your heart rate's up. You're going to be hypertensive, and this is going to continue and continue and continue. We are designed to have short-term effects on this. We're designed to have short-term blood pressure issues. During fight or flight, blood pressure goes up because it's supposed to, because we're trying to do something, stand and fight or run away or process or something. This is not designed to be a continuing event or continuing activity. If you're hypersecreting epinephrine, it's going to keep lasting and lasting and lasting. Agitation, constant agitation, it's going to be going on here. Your patient will be unable to relax of any kind. Typically, it's going to be caused by a tumor in the medulla of the adrenal gland. So, because this is uncontrolled release of large amounts of epinephrine from the medulla is not a normal situation. So something has to trigger it. Nearly always it's going to be a tumor. So now, moving past the adrenal glands. We've got this little gland called the pineal gland, and it really is a little gland. It is in the brain. It is at the base of the thalamus. If you remember from AP1, when you saw a slide showing the corpora quadrigemina, remember the corpora quadrigemina? And it usually, the picture usually has the corpora quadrigemina bent down, and maybe up in the middle of the picture, you can see a little structure hanging down between the cerebral hemispheres. That's the pineal gland. It is right at the extreme posterior surface of the thalamus, and it is responsible for secreting melatonin. Melatonin is a regulator of our day-night cycles. It is our tells us when to sleep and when to be awake based on light input that our eyes pick up. You know, like right now, we're getting visual cues from daylight. Well, our pineal gland is not secreting a lot of melatonin right now. But when it gets dark, the visual cues of it being dark outside, the melatonin will start upping the pineal gland will up the amount of melatonin, and that'll make us tired. It'll make us sleepy. It'll make us want to go to bed or go to sleep at least. And this is what this is how we regulate our day-night cycles. When it gets dark, melatonin goes up, we get sleepy. When it gets light, melatonin goes down, we get awake. And it's hard to deal with changes to our schedule when our pineal gland is busy saying, hey, it's dark outside, let's go to bed. And your work schedule says, oh no, you have to work 11 to 7, or 3 to 11. You're working during hours of darkness. The body doesn't like that. The body has a hard time adjusting that simply because of the presence of our melatonin. Melatonin has a big role to play in maturity, physical maturity. As we go through puberty, we secrete more melatonin. It may even have, during puberty, it may even have an impact on development of the secondary sex characteristics. And there is the location of the pineal gland right there. It is suspended right between the cerebral hemispheres here, just about the level of the occipital lobe, and it sits just above the corpora quadrigeminum. Corpora quadrigemina. Geminum, where did that come from? Corpora quadrigemina, hanging suspended here. And if you could, I don't know if the next picture shows it or not better, but no. The pineal gland, if you go forward, you would see that it then runs into the thalamus. So that midbrain area is all connected. So it is not a very large gland, but it plays a big role in day-night cycles for us. It maintains our circadian rhythm. And a lot of our activity depends on the visual cues we get from our eyes. Dementia patients, it's totally unrelated to the pineal gland. Dementia patients have issues when it gets dark. Dementia patients, there's a term called sundowning, where your dementia patient will start losing their visual cues and start becoming more disoriented because it's not light outside. They're not used to it for whatever reason, even though they should be, but they lose their visual cues. Their disorientation level goes up. So, and it may end up have something to do with the presence of melatonin that they can't process. Okay, now the pancreas. And this is going to lead us into our discussion on diabetes. So the pancreas sits on the left-hand side of our bodies, right underneath the stomach. It is just often described as tadpole shaped. I guess you can imagine it looks like a tadpole. The pancreas does double duty though for us. It is both an exocrine and an endocrine gland. It's exocrine in the sense that it releases pancreatic enzymes through a duct into the small intestine to help digest proteins, and it releases insulin and glucagon from its the islets of Langerhans. And insulin, of course, allows glucose to go into the cells, and glucagon allows glucose to be formed from the liver from the stored glycogen. So if our blood glucose level goes up, we release insulin. If our blood glucose levels go down, we release glucagon. Okay. So we have the types of cells in the pancreas. We have the acinar cells or acini cells. They are part of the exocrine aspects of the pancreas. The acini cells produce digestive enzymes to finish the breakdown of proteins. We start digesting proteins in our stomach and we finish it in the small intestine. And so we're busy producing these digestive enzymes from these acini cells. Now, embedded within the acini cells, scattered throughout the pancreas, are the islets of Langerhans, or the pancreatic islets. These are the endocrine structures in the pancreas. The alpha cells produce glucagon. There's two types of cells in the islets of Langerhans, alpha cells and beta cells. The alpha cells produce glucagon. Glucagon acts on the liver to tell the liver to start breaking down glycogen into glucose. So when we need glucose to bring our blood sugar levels up, our blood glucose levels up, that's what glucagon does. Islets of Langerhans, the alpha cells release glucagon. Glucagon acts on the liver releases glycogen and breaks it down to glucose, and our blood sugar level comes back up to where it belongs. And then the beta cells go to work because the beta cells produce insulin. Beta cells produce insulin. The insulin opens up channel proteins in our cell membranes of all of our cells, and the glucose that we've brought up can now go into the cells and feed the cells. That's how they work. They are antagonistic, but they have to, they work together. They work together. The alpha cells make sure our blood glucose levels don't drop. The beta cells make sure our blood glucose levels don't get too high. And this is what the islets of Langerhans looks like. Little clusters of hormone producing cells in the middle of the acini cells. The acini cells surround the islets, and you can see the alpha cells tend to stain dark. These are the glucagon producing cells, and the beta cells stain light, and they produce the insulin. Glucagon is an antagonist. If blood sugar goes up, insulin lowers it. If blood sugar drops, glucagon raises it. So that makes them an antagonist. It will always respond to low blood sugar levels, but it will also respond to the sympathetic nervous system when we have a fight or flight response. Remember I said that the medulla of the adrenal medulla is under control of the sympathetic nervous system. Well, the sympathetic nervous system in a fight or flight response will also trigger the release of glucagon because we need energy. We need lots of energy during a fight or flight response. And the combination of glucagon and epinephrine gives you that synergistic response. I think I mentioned that earlier, that you can be antagonistic or you can be synergistic. A synergistic response enhances the overall response. So the combination of glucagon and epinephrine give you more glucose coming out in a fight or flight response than you would get from either one individually. So with synergism, you get, instead of 1 + 1 = 3, you get an enhanced response. So glucagon, breaks down glucose, breaks down the glycogen through glycogenolysis. It triggers the liver to do that through glycogenolysis, so the lysis of glycogen. It also triggers gluconeogenesis, the creation of new glucose. Genesis means creation. So gluconeo means creating new glucose from breaking down fats like fats and proteins. Lactic acid can be converted to glucose. The fatty acids can be broken down into glucose. Proteins can be broken down to glucose. So we have gluconeogenesis. When we need more glucose, glucagon can do all this for us. Now, insulin, the antagonist to glucagon, comes out when our blood glucose levels go above the set point, go above a normal level. Whether you are raising your glucose with glucagon or you had a chocolate donut, whatever, your blood glucose levels go up. So your insulin gets released from the pancreas. The pancreas will release a type of insulin known as proinsulin. Then proinsulin becomes essentially activated to insulin. And what it will do is insulin allows the development of more channel proteins in the membranes of our cells. As it says here, enhances membrane transport of glucose into fat and muscle cells, meaning that the cell membranes create more channel proteins. Because glucose is too big to go across the cell membrane by itself, and it's also not fat soluble, but if you have a channel, it'll slide through the channel. So that's what we do. We make channel proteins in the cells, fat cells and muscle cells, so we can bring the glucose in. Now, some of the glucose is going to get used right away for energy, and some is going to go to the fat cells, the adipose, and get stored there. And some is going to go to the liver and get stored there as glycogen. Insulin also stops the breakdown of glycogen to glucose. So if you raised your glucose levels by glycogenolysis, insulin's going to stop that. And insulin's also going to stop gluconeogenesis when necessary. Insulin doesn't do anything for the liver, for the kidneys, or the brains. Insulin is responsible for getting the glucose into all the other cells. That's how we feed the cells. Cells depend on insulin. Most cells in our bodies, except for the liver, the kidney, and the brain, depend on insulin to open up those channel proteins for us. So we've got to have insulin, just like we have to have glucagon. Okay, things that really cause insulin to come out, obviously a rise in blood sugar levels, that will trigger it. That's the #1 trigger, but we can also see a spike in fatty acids, and amino acids. If we're breaking down proteins and fats to make glucose, then we're going to see amino acids in our blood, and we're going to see fatty acids in our blood. If we have a spike in acetylcholine in our blood from parasympathetic activities, remember the parasympathetic nervous system uses acetylcholine as its neurotransmitter for everything. And so if we see a spike in acetylcholine, we can release insulin. So we see different hormones here may also, a rise in other hormones may trigger a rise in insulin too. #1 source of insulin, an insulin spike, is still going to be elevated blood glucose levels. So whether it's from from glucagon or whether it's from eating anything, anything with carbohydrates in there. So after we get the after insulin opens up the channel proteins for us, the glucose goes into the cell, and insulin's not done yet. Insulin then triggers the metabolic activity that produces ATP in the cells. So it can do that. It can also form glycogen. It can, glucose can be used to form glycogen. And it can also tell the fat cells to suck up extra glucose. So consider this, you have, your patient is maintaining a high carbohydrate diet. Now, some of those carbs are going to go into the cells and feed the cells. That's what insulin does. It opens up the channel proteins. Insulin goes in, insulin opens up the channel proteins, glucose goes in, and the insulin tells some of that glucose to be converted to ATP, to make ATP with the power of that formation. Some of it, if not all the sugar is being used, then we store some of it as glycogen. But we can also store glucose as fat. So a person that, because the question would be, how do people become overweight if they eat lots of carbohydrates? Because carbohydrates are ultimately become glucose. Well, excess glucose ends up becoming stored as fat in the adipose tissue. So a person that would eat a lot of carbohydrates, more than they need, we talked about this in AP1, if they eat more carbs than their body can use, then they're probably going to start storing the excess in the adipose tissue, and you can see a weight gain in here. I had a friend of mine years ago she worked for the State Department, and she got posted at the embassy in Paris, hard duty to be in Paris, and she said that every day they would go around the corner from the embassy to this little bakery. Imagine that there was a bakery in Paris, and they would have hot rolls and butter every day. And at the end of her year there, she had gained 60 pounds, and she couldn't figure out why. Because she said, I wasn't eating anything, any pastries or anything like that. I was just eating bread and butter every day. That'll do it. Yeah. The carbs, the excessive amount of carbs that she took in found their way to her adipose cells. I didn't tell her that. That was, but that's what was happening, and it was, it would be a very, it's one of those subtle little things that you don't pay attention to. Oh, bread and butter, this is good. French bread, right here, you eat it every day and it's going to sneak up on you. So one of the reasons why our patients that we have are going to have problems with weight gain is, a lot of it is based on diet. A lot of it is based on, carb consumption, fat consumption. Most healthcare providers will tell you that the carbs are really the problem and not so much the fat. I know my family doctor likes to tell me, carbs, he says carbs are evil. Well, I don't know if they're evil, but excessive amounts of carbs are not necessarily a good thing, because, if some is good, more is not always better. So it's all about moderation in that. Many of your patients are going to be maintaining a high carbohydrate lifestyle. Just look around where we live. Look at the patients that you have. Look at the patients. Look at the people you see in public. Many, and I don't want to be critical or mean, but many of the people that we encounter in Tennessee, particularly East Tennessee, have some real weight issues. So, some significant weight issues. So, anyway, yes.
So I think it would be better to say that it's basically the whole U.S. because the whole U.S. has that issue. But my question was, so I went to Germany with my mother in 2018, and I noticed I'm someone who gets bloated very easily with certain food groups, and I noticed while we were there that I didn't have those issues when eating the same food groups, and I talked to several other people who have been out of the U.S. and they've said the same thing. I know that some people who have gluten allergies, they can eat gluten in other countries and be fine. So is that what would cause that? I guess they just cook different than we do, or
Well, it may be the way they process, they bake their their breads and their rolls. It may be, because I know that our pastor's wife was from Germany. They since moved, but she would always bake a lot of breads and rolls and stuff, particularly like at potlucks and things like that. And they always tasted better and different than anything store-bought around here, or even at somebody else's homemade bread. And it may be the way that the grains are processed, maybe the way that they're taught to bake. I don't know. But I could. She used to make this bread at Easter that you just wanted to keep eating. It never bothered you. So I mean, I don't have any issues with. I never met a piece of bread I didn't like. I'll just say that. But I never had any gastric issues with it. And it may be the source of the grains that in Germany, where are they getting their grains from? Most of Europe gets their bread, their grains from the Ukraine. It's, as they say, the bread basket of Europe, if you will, because they have very fertile fields for growing lots and lots of grain. They're a huge grain producer. And it may have to do with the type of soil, the type of grain they're growing, the type of wheat that they're growing. Who knows? Maybe their wheat isn't as genetically modified as perhaps ours is. So don't know. So I may have to make a trip to Germany sometime and study that. So, okay. Now, insulin, again, insulin is driven initially by high blood glucose levels. That's the driver. The pancreas will secrete insulin when the blood glucose levels go up. That's what it does. If we see, all these other hormones, if we release glucagon, because you forgot to eat this morning and you bring your blood glucose back up, you still have to release insulin to put that glucose into the cells. It's not enough to bring your blood glucose up. Okay, you didn't eat something. So you released glucose from your liver, through glycogenolysis. Well, that's fine. It brings the blood glucose up, but the cells are still hungry. So you still have to release insulin to get the glucose to go into the cells. So presence of glucagon, epinephrine during the fight or flight response, you're going to release a lot of glucose. Now, epinephrine tends to inhibit the actions of insulin. Insulin doesn't respond very quickly in a fight or flight response. We're not going to shut down the release of all this glucose in a fight or flight response. We're going to use that glucose to go into the muscle cells. The insulin's going to work on the muscle cells, for example, so that we can have lots of energy. But it's not going to pay attention to the rest of the cells, and it's not going to be trying to drive the glucose levels back down. So insulin doesn't operate in a vacuum. There's lots of things that have to go into play here. Okay. So our blood glucose level normally runs between 70 and 110 milligrams per deciliter. A deciliter is 1/100th of a liter. And so we monitor our blood glucose levels. Whenever we have any kind of blood work done, we'll get a report that shows your blood glucose is at 75 or 80, and your healthcare provider is really happy. Or your blood glucose level is 115, your healthcare provider is not happy at all. So, but we try to stay somewhere in that range. It normally runs that level, like at night when we're asleep, our blood glucose levels drop. We wake up in the morning and we're usually hungry. We want to eat something. And so we eat something and bring our blood glucose levels up. And we usually go past our normal range, and then we release some insulin to put that glucose into the cells. And we try to keep this nice constant level here all the time. Yes, we'll have a spike when we eat a large meal, and then it'll drop down. But we want to be, over the course of a 24-hour period, we want to stay with a consistent level. When you go to have blood work, what do they call it? The fasting blood level. You don't want to. They don't eat anything that, from the night before and so on. And that's fine, because we want to get a valid number there of what your resting level is. Yeah.
So when I was younger, I had a history, and I still kind of do, but it's gone away as I've gone older. But I used to have episodes where I would just kind of pass out, and or at least like get that really fuzzy, seeing things black kind of thing. And that happened one time when I was at a band event, and I ended up being put in the ambulance. I didn't actually go anywhere, but I was just put in the ambulance, and they thought I was diabetic, but I'm not. So like, why would that happen? Because that used to happen to me all the time, especially like at band events. Maybe because it was hot, I don't know, but
Well, it could be that. You know, it sounds like your blood sugar levels, your blood glucose levels dropped significantly today. Were they ever tested?
I think they were, but I don't recall what they had said about it, because it was something that was very common for me at band. And I actually ended up having to quit band because nutritionally I wasn't healthy enough. I'm a recovering anorexic.
Okay.
So, but nutritionally I wasn't healthy enough. And because I had the last year that I was in it before I quit, I passed out like almost every time we were on the field, because I don't know, I just would fall over and pass out. So I was just curious.
Well, I mean, you know, it may be that there becomes a certain level of stress, and because if you've done it once, then you're concerned, am I going to pass out again? And then it might become a self-fulfilling event.
You're right.
It also, if your blood sugar levels do drop, you know, and you're not releasing enough glucagon to bring it back up, that would definitely cause you to, without sugar in your system, you're going to definitely not have enough energy, and that could cause, you know, to pass out too, you know, or if nothing else, feel lightheaded because of the lower blood sugar. It could be, you know, you were in a conversely, what if you got so excited about, you know, being on band and not aware of it, that you were dumping out large amounts of glucose, you know, and your body's response was, I can't deal with this, and just sort of shut down. You know? So there's any number of things that could. Has it happened since you stopped?
It has a couple times, and most of the time my mom, like when it happens, she'll just bring me a cup of orange juice and make me drink it.
Okay. Well, in that case, I would say it sounds like it's probably not enough sugar in there, because the classic treatment for when you're hypoglycemic is orange juice with some sugar thrown in there. So that sounds like, you know, that your blood, if that brings you right out of it, then it sounds like you were hypoglycemic instead of hyperglycemic. So that's probably the case. In fact, there was something in the news just recently. This is really fascinating. There were two sisters traveling recently, and there was a diabetic emergency on the plane they were on. And one was a paramedic, and the other was a nurse practitioner. And so they volunteered, and they went over to the patient, and she was semi-conscious. And one of the things about a diabetic emergency is always give sugar. It doesn't matter if if your sugar levels are too high, a little more sugar is not going to hurt the patient. You know, you're not going to, if they're going to die from too much sugar, your extra sugar is not going to kill them. But if their sugar levels are very low, and you give them sugar, it'll bring them out of it. And what they did was they took granulated sugar, little packets of sugar, and placed it under her tongue so she could absorb it right away and she couldn't, because, you know, it'll dissolve. So whether she was semi-conscious or not, didn't have to worry about her aspirating on something to drink or eat, just underneath the tongue, and she came out of it. She was having a hypoglycemic event, you know, so, and I'd never heard about that approach before, but that was pretty interesting. So, and of course, the Delta probably charged him extra for doing that. So who knows? I don't know. But that was, you know, that's one of the things about a diabetic emergency is you generally can't make it worse if you give them something with sugar in it, you know, because if their blood sugar levels are so high, if their emergency is because they're hyperglycemic, a little more sugar that you can add is not going to make it worse. But if they're hypoglycemic, you'll generally bring them out of it. And that's what the orange juice was doing for you.
Okay.
So, okay. Now, the biggest problem we have with the pancreas and insulin and glucagon, of course, is diabetes mellitus, the #1 endocrine disorder around the world. Diabetes mellitus, the term means overflow of honey, because when a person is experiencing, has diabetes mellitus, or just we'll call it diabetes, they are generally not getting the sugar into their cells, either because they're not producing enough insulin or the insulin's not being recognized. And so the sugar has to go somewhere, so the glucose ends up in their blood, stays in their blood, and usually ends up in the urine. And the urine is very, very, is packed with glucose, and it has a very strong, sweet odor to it. So there are 3 signs, 3 cardinal signs for diabetes mellitus. What we call polyuria. Your patient is peeing all the time. The high level of glucose in the filtrate from the kidneys, because the glucose is a small molecule, and it goes through our kidneys, and it passes, because it's such a small molecule, it ends up going through the kidneys. And ends up in what would normally be the urine. In a healthy individual, yes, the glucose is filtered into the what would end up as urine, but we recover all that glucose before it ever gets to the bladder. So all the glucose that we have in our plasma is brought back, stays in the plasma. We don't pee it away in a healthy individual. However, if we have so much glucose in our plasma, we will tend to, and we're not recovering it, we tend to suck water out of our blood vessels through osmosis. The capillaries, the blood vessels run side by side with the kidney tubules, and we'll talk all about that when we get into fluid and electrolytes later in the semester. But what happens is that high levels of sugar, and when I say sugar, I mean glucose, high levels of sugar in the filtrate from let's just say in the urine, draw lots of water from the blood vessels around it. Simple osmosis, water goes from high water to low water. There's more water in the plasma than there is in the filtrate. So we draw that away. That puts lots of water in our bladder. So that we pee a lot because the glucose is drawing water away from the blood vessels. So we're constantly peeing. Well, when we pee like that, it's going to make us thirsty because we're drawing water away from our plasma. So first sign is polyuria. Patient pees all the time. Second sign is polydipsia. They're thirsty all the time. And the one that gives it away as diabetes mellitus is polyphagia, a constant hunger, because the cells are not getting fed. If you don't have enough insulin, you're not letting glucose into the cells. If the insulin you're making isn't working, you're not getting glucose into the cells. The cells are hungry, and the only way that we know how to respond is to continue to eat. So diabetes mellitus is a very common disorder. We have lots of it in the US. We have lots of it in the South. We have many, many cases in Tennessee. We're probably in the top 10 for diabetes in the US, along with obesity and heart disease and various other disorders. Now, there is a condition known as hyperinsulinism, where we may secrete too much insulin. And then our problem is our patient is hypoglycemic. Too much insulin means that there's not enough glucose in the blood. We're sucking all that glucose into the cells. And so we don't have enough glucose to go around because we are sucking too much in. We're not storing any of it. a hypoglycemic patient is going to, they're going to pass out. They're going to be disoriented. Their blood glucose levels are very low. So simply because they're overproducing their insulin. So diabetes mellitus, most common endocrine disorder around the world. There are type 1. There are two types, type 1 and type 2. In type 1, you're not releasing enough insulin. The beta cells in the pancreas and the islets of Langerhans have usually become non-functional. Often it's triggered by some sort of autoimmune response somewhere early in life where the beta cells are attacked. We often call it juvenile diabetes. The beta cells are attacked and destroyed, and there aren't enough beta cells to produce insulin. So that's type 1. It's less common. The most common type is type 2, where the insulin that's being produced is not recognized. The cells tend to downregulate the insulin so that the insulin doesn't have a lot of opportunity to function. You're churning out a lot of insulin with type 2 diabetes, but the cells aren't recognizing most of it. The cells ultimately will, if you're, one of the simplest approaches to correcting type 2 diabetes is weight loss. And if your patient loses sufficient weight, then their cells start recognizing this insulin again, and their diabetes goes away. It's many times where someone has gone through a strict weight loss program or gone through some sort of gastric bypass, and the lack of carbohydrates being absorbed in their gut, their type 2 diabetes ends, goes away. They recover from it. So now what will happen here in diabetes is the excess glucose. You're not dumping glucose into the cells like you want, because you're not. That's what insulin does. Insulin allows glucose to go into the cells, and what will happen is in either type 1 or type 2, since the insulin's either not there or not working, glucose doesn't go into the cells, and so the extra glucose ends up in the urine. So, and if we have any kind of sympathetic response going on, then we're going to have even more glucose being dumped out. So this condition, glycosuria, too much glucose in the urine. We should have no glucose in our urine. When you have urinalysis done, all your glucose should be recovered. It's a small molecule. It gets sucked back in the kidney tubules, and there should not be any in our urine. So type 1 diabetes, early onset, childhood diabetes, juvenile diabetes, no insulin produced. Don't know why. Autoimmune disorder? Could be. I had a friend when I was a kid, he had developed measles. He had missed his vaccination for measles. And shortly after he recovered from measles, he developed type 1 diabetes. Is there a link? I don't know. Usually what happens is something has to destroy the beta cells in the pancreas, and that's what happened to him. The problems with diabetes, our type 1 diabetes, your patient will develop long-term issues with blood supply and their nervous system. Usually what we see is what's known as develop very poor peripheral circulation. The vessels in the extremities narrow. It may be because of accumulation of fatty deposits in these vessels, but we reduce the flow to the extremities. So we have very poor peripheral, meaning extremity circulation. So if they have an injury in the extremity, it doesn't heal very well, and it's possible that they can develop gangrene or other types of issues, infection and gangrene, and perhaps lose a structure. They also have neuropathy or nervous conduction. They don't sense things as well. A very common problem with diabetes is an individual will bruise or injure their foot, for example. They'll bruise their foot, but they won't notice it. Where someone who doesn't have diabetes would walk into something and it would hurt. Oh, that hurts. I tripped over something, or I walked into something, and it hurts. Well, your diabetic patient likely won't discover that they walked into something and bruised themselves for many days. Because first of all, they couldn't feel it because they have poor nerve sensation. That's the neuropathy. And the bruise or the injury didn't heal properly because they had very poor circulation. And the bruise, instead of healing, starts to become infected. And a lot of times the first indicator that there's something going on in the foot may be because they don't feel it, they don't notice anything until they smell it. They smell the rotting tissue when they have gangrene. So that's one of the key problems there. It's a very common problem. You'll notice that we have lots of wound clinics in Tennessee because diabetic patients often have lots of injuries to their hands and feet because an injury won't heal right. And so they have to be treated, specifically for those injuries. We also see problems with atherosclerosis, heart disease in your diabetic patient. The poor circulation also applies to the vessels in the heart. And so it's very easy your diabetic patient may not live as long as they could because, if they don't maintain a good diet, their heart, they can develop some sort of type of coronary artery disease. A very common condition is blindness. The poor peripheral circulation affects the blood supply to the retina. And it's not unusual for that to impact the retina and start destroying the rods and cones in the retina, and your patient will go blind. I had a friend in college who had type 1 diabetes, and from his freshman year to his senior year, he went completely blind. Simply because of the blood supply to the retina was impacted and shutting down. Again, no fault of, in type 1 diabetes, no fault of their own. We don't know what triggers it. It might be autoimmune in nature. It may be viral in nature, but something shuts down the beta cells in the pancreas. Now, type 2 diabetes, we're definitely producing insulin, but the insulin's not being recognized. This generally starts in life somewhere, we used to say it started an individual that was overweight and over 40. But we're seeing a lot, as our society becomes more and more overweight at earlier and earlier ages, we're starting to see type 2 diabetes showing up in younger people. We say it's later onset. I said late, I ought to change that and make it later onset. We are not producing enough insulin that's recognized. Lots of insulin's coming out, but the receptor cells are not responding to it. Most of your patients that have type 2 diabetes are significantly overweight, into the obesity range, into what is characterized as being obese. So, and so you're, in both cases, many of them are going to have to depend on some sort of insulin, a synthetic insulin to treat that. The thing about the type 2 diabetes is this adult onset diabetes was simply mostly caused by lifestyle, you know. And of course, if your patient is dealing with obesity and being overweight and developing type 2 diabetes, the weight gain is probably going to be triggering cardiac issues too, you know, because our heart doesn't like to have extra mass and extra fat to carry around. That the extra weight causes the heart to work harder. Plus, the the high calorie diet may lead to coronary artery disease as we start laying down cholesterol and plaque in the coronary arteries. So there's a lot of bad things that are going on there. Now, one of the more serious conditions that can occur, one of the more critical diabetic emergencies, is something called ketoacidosis. An individual who has diabetes that's uncontrolled, their blood glucose levels may be elevated. Normally it's supposed to be under 100, theirs may be 600. But the cells are starving. The cells are not getting any of that glucose. And what your patient will do is start undergoing gluconeogenesis. They will start breaking down their fats and their proteins to generate glucose. You know, it's what our bodies do. Well, when we break down fatty acids, you know, because if you remember, lipids are fatty acids and glycerol. Glycerol alcohol molecule has 3 fatty acids attached to it. That's a lipid. We start breaking that down, and when the fatty acids break down, they form ketone. Ketone is the substance that we find in fingernail polish remover. It's acetone, you know. And as we continue to break down more fats, we form more ketones. Now we continue to process the ketones into glucose. However, as we break down these fatty acids, we make lots of ketones. Your patient will have some very distinctive symptoms. The first symptom is they're going to be hyperventilating. They're going to be breathing rapidly. Because when you dump extra acids into the blood supply, it lowers the pH of the blood. The blood gets more acidic. Your medulla oblongata, you know, in your respiratory center says, oh, hey, you know, my blood pH is down low. I must have a lot of CO2, because CO2 is what regulates our breathing rate. We must have a lot of CO2 because I'm getting acidic. I must have a lot of carbonic acid. So let's breathe fast. So your patient will be hyperventilating because the medulla oblongata thinks it's because of carbon dioxide. It's not because of carbon dioxide. It's because the blood has gotten more acidic because of these fatty acids that are being broken down. But the second characteristic, the real giveaway, is their odor. Acetone, if you've ever used fingernail polish removers, has a very pleasant odor to it. Acetone, it's, you know, we use acetone all the time in organic chemistry to clean glassware and in different chemical reactions also. It has a very pleasant smell. It has a fruity odor to it. And your patient will have a very distinctive fruity odor. It's like if you ever smelled juicy fruit gum, which is a very sweet, penetrating odor to it. That's what their skin and their breath will smell like. So they're hyperventilating and they smell fruity because they're generating all these ketones, these acetones. And so they're hyperventilating, smell like a fruit. Their skin's going to be very, very dry, and they're going to die very quickly if you can't treat them. This is a very dangerous situation for your patient to go into ketoacidosis. Their blood pH is getting more and more acidic, and our bodies don't like extreme ranges in pH in our blood. Our enzymes start shutting down in here. It's as bad as raising or lowering our body temperature. So, and you know, our body doesn't know why we are breathing, why our blood pH is so acidic. So our basic response is, I'm going to hyperventilate to get rid of all that CO2. That must be my problem. It doesn't know what else is going on. So, okay. So who has it? Well, we have about 1.5 million people with type 1 diabetes. Again, the beta cells get destroyed. The number of people that have type 2 diabetes, there's about 30 million of those. 30 million people have type 2 diabetes. But there's probably another 30 million that are in a pre-diabetic condition. They don't have full-blown diabetes mellitus yet. They don't have type 2 diabetes mellitus yet, but they are on the verge. So probably 60, 70 million people are either diabetic, have either type 2 or are pre-diabetic type 2. That's a lot. So, and there's probably about 7 or 8 million that have it and don't know it, which is hard to imagine. So the grand total is about 30% of the adult population in the United States are either diabetic or pre-diabetic, about 84 million people. You know, that's a lot of people. So, and a fair number of older Americans have it too, are part of this. You know, if your patient is older, 65 years or older, about 1/3 or so of your patients are probably going to be diabetic also. So of the 84 million people that are diabetic or pre-diabetic, about 1/3 of those are over 65. So it's not a function of age. It's a function of, you know, obesity. You know, it is brought on primarily by weight gain. You know, and you're going to have lots of patients that, you know, they're 90 years old or 100 pounds overweight and they are healthy as that proverbial horse. You know, they're the outlier. They're not going to be your normal patient, because you're going to have lots of patients that are 50 years old and 100 pounds overweight and have type 2 diabetes and have heart disease and high blood pressure and everything else going on too. A lot of it depends on diet and exercise. Okay. We can see how it's rising. You know, this goes up to 2016, which was actually, you know, hard to believe that was what, 6 years ago now. But the numbers are still continue to climb, rise here. Here we can see, if we look at this shows you the increase in diabetes over time from 2015 to 2030. We can see how you know, the South is very big in diabetes. Our numbers continue to climb faster than the national average does. So, and for whatever reason, some states are just, you know, I tease my wife every time I show this. I said, and look, there's West Virginia. She's from West Virginia. West Virginia is leading the pack, you know, so she doesn't like that. But, you know,
I feel like a lot like in the South, it could also be because I mean, I know the northern states do too, but like the South is known for fried food.
oh yeah, yeah.
So I'm sure that has a lot to do with it.
That has a lot to do with it. It's the food that we eat in the South. You know, we like our fried foods. We've had fried foods for forever, and we eat a lot of it. You know, I know the northern states eat a lot of fried food too, but apparently we fry everything. You know, wasn't the deep fried Twinkie invented in the South? You know,
Probably.
so I can truthfully say I've never had one, but that's, you know. But yeah, you can see the pattern here is that on this map, you can see how it just continues. You know, it's projected to just get worse and worse over time. And even the what you would say the healthier states, the Western states, where you would expect to see a little more restraint, you know, it's still, you know, increasing there too. So, yeah, Okay, now this, I went too far. Hang on a second. I want to make sure I didn't get too far. Okay, this next one compares obesity and diabetes rates in the US. And the top one is obesity and the bottom one is diabetes for a 20-year period. And you can see how they track together. As body mass increases, the cases of type 2 diabetes goes up too. I'm not telling anybody in this class something we already knew, but you can see how it tracks pretty well. So, areas that are affected: the brain through peripheral neuropathy, the eyes with blindness, the heart disease, the pancreas obviously is shut down and producing insulin. The kidneys are trying to filter all this glucose out and drawing excessive amounts of water from the blood supply, so it's affecting the kidneys. The gangrene, the rotting of the tissues because of neuropathy, where you don't feel the pain, and the poor circulation. These are all the impacts that you encounter here. Now, diabetic retinopathy. This is a big one. This causes blindness. Our retina has many capillaries that supply all those thousands and thousands of rods and cones that allow us to see. But what will happen here is that the capillaries that are supplying the rods and cones will leak and they will swell. And so they will shut down the blood supply to the photoreceptors, and the photoreceptors will die. And so we have a gradual occurrence here, a loss of visual acuity with loss of vision. You can see that the normal retina on the left versus the one on the right. You can see all those dark red spots there that are occurring. That's because those are areas that are shutting down because of clotting and of hemorrhage in here, swelling, killing off the photoreceptors. So, and then of course we have the peripheral neuropathy. The nerves become damaged. The action potentials can't run through the nerves, and we become desensitized to pain. Injuries are not detected. Pain's our body's way of saying, stop, don't do that. And if we don't detect it, then we can't respond to it. We don't respond, and our patient becomes the injury. We don't detect the pain, we don't detect the injury becomes infected, and then we have the poor circulation. So we're not bringing in oxygen and red and white cells to fight the infection because we have this poor circulation too. And we have situations like this, where we have the circulation becomes so bad. Gangrene is a bacterial infection. Yeah, I know. I always like to show this right before lunch. Gangrene is a bacterial infection caused by what's known as the Clostridium bacteria. It is an anaerobic bacteria. It doesn't require the presence. It does very well without oxygen, and it is a very insidious, very sneaky infection, and that it rots away the tissues. And your first indicator that your patient has this is it has a horrible smell as the tissue rots. So you can see like tips of the fingers are coming off. You can see how the toes are lost there. I would say the foot is probably lost also in this case. Here's another one that I've used this for, you can see, look at the inflammation, all this redness along here. Inflammation is a good thing for us. Inflammation is our body's way of fighting infections. But here the inflammation is showing that we're being overwhelmed. This foot is lost. Look at the poor circulation up in here. This foot is probably lost at this point.
One of my friends that I met in Morristown campus, her mom, last semester had to get one of her legs removed above the knee because she had, I don't know if I don't know if she actually had diabetes or if she just had really bad circulation in general, but she had really bad circulation and her foot looked like that
Mm-hmm.
and ended up dying off. And my friend, like, she kept messaging me because, I mean, I'm not like a nurse or anything, but I mean, I've grown up around nurses my whole life. My mom is one. So I know, like, a fair share of basic things. And she would always send me pictures of it and be like, I think it's getting worse. And I'm like, yes.
Mm-hmm.
So she ended up getting it removed.
Oh, yeah. My great grandma had a one of those old fashioned sewing machines. It was treadle powered. You had to push on it with your foot. And she bumped her foot one day and it got infected. And she was a type 2 diabetic. And they ended up having to remove her leg below the knee. And she lived for another 9 years after that. She was like 80 something when it happened. So she was like 90 when she died. But she lost her leg because of same situation. She didn't know that she had bruised her foot. She didn't know that it was infected until she finally saw it. And it stank. And she went to her doctor and he put her in the hospital right away. So she recovered from the surgery and she lived for another 9 years. But again, a simple thing like bumping her foot is what did it because of the poor circulation. So, okay, I think I already mentioned this. If your patient has too much insulin, they are usually going to be in a low blood glucose level. Treatment is always to give them sugar, in some, so that hopefully so that they don't aspirate the sugar, but too much insulin, and this can happen if your patient is using injections or if they have a pump or something and they get it wrong, get the numbers wrong. They're going to be hypoglycemic because they've sucked up too much glucose. They may become disoriented, they may become unconscious. The treatment is always some sort of sugar to try and eliminate the excess insulin. Okay, a couple other things here. The gonads and the placenta, the ovaries will produce estrogen and progesterone. Estrogen is the female sex hormone. Progesterone, as we mentioned in lab this week, is what keeps the lining of the uterus intact at least for 7 days after ovulation, or perhaps during pregnancy for the first 3 months before the placenta takes over. The placenta will then release progesterone and estrogen and HCG, human chorionic gonadotropin. That's what shows up in the pregnancy test kits. Okay. So the ovaries are going to contain produce estrogen and progesterone. Estrogen is, again, during puberty is what triggers the development of all the secondary sex characteristics. It maintains the lining of the uterus. It builds up the lining of the uterus in anticipation of a pregnancy. And then progesterone stimulates breast development during puberty. It also tells the uterus when to let go of the lining. The stratum functionalis, the lining of the uterus that would receive a fertilized egg, is held attached to the uterus because of the role of progesterone. Progesterone keeps that attached to the lining. When the ovary stops making progesterone, then that lining lets go, and that's what causes menstrual flow. Okay. In the male, the testes produce testosterone. They produce testosterone in these cells called the interstitial cells, sort of tucked in here along the sides. These are all seminiferous tubules, and these interstitial cells here are going to produce testosterone. Testosterone drives the male secondary sex characteristics during puberty, body hair, facial hair, sperm production, all that. Males need testosterone for masculinization and also sperm production and to maintain the function of the reproductive structures. Testosterone will get produced starting in puberty and will continue until death. So a male is capable of producing sperm from the onset of puberty until the day they die. Not, just because they can doesn't always mean they should. Just leave it at that. So, and this shows you what sperm cells are doing. These sperm cells here are busy trying to burrow into an egg. By the time we get to sperm cells reach the egg, there's about 400 million sperm cells released during an ejaculation, and we have a few thousand by the time they get to the egg, and the heads of the sperm contain digestive enzymes that they're trying to digest away the outer coverings of the egg so that the nucleus of a sperm cell can penetrate the cell membrane of the egg and fuse with the nucleus of the egg. So, and we'll just let that, we've mentioned all that, the rest of it we'll mention. So, and we are done with endocrine. So I would suggest that we might want to consider having our first test next Wednesday. Monday is Labor Day, so we won't be here. Nobody will be here. You come to the door, you'll be banging on the door. No one's going to answer because we won't be home. But I would suggest that you'll have a week to get ready for it.
So, on test day, like, I know you said it could be in person or online, so we have lecture that day, or is it just gonna be a test day?
If everybody, what I like to, since I'll open it up, I mean, we can have lecture, because are you going to take it on the ground or online?
I'll probably take it online,
What about you?
probably online.
I would imagine everybody's going to take it online. If anybody wants to take it on ground, let me know, that's fine. But I will go ahead and plan on lecturing on Wednesday and have the test posted online for everybody. So, and I'll give you like 24 hours to take it, it won't be like, take it at 11 o'clock. No, I'll give you like a 24-hour window to take it.
Do you
Okay.
open it like on Wednesday or like Tuesday into Wednesday?
I'll probably open it Wednesday morning at 12:01 and run it till Thursday night, Wednesday night at 11:59. So I'll give you like a 20, or I'll run it in this. I may run it 2 days. I don't know. I haven't said. You'll have a nice window to take it. So don't,
Okay.
it's not like how, here, you've got 15 minutes, go take it, So no, I'll give you
How many questions are your tests
a
usually?
50,
50?
usually 50 questions.
Okay.
So.
How long do you usually give us to do it, like the class?
I usually give you for a 50 question test, I'll give you about 50 minutes. That's a minute a question. And some questions you'll just blast right through, and some will take a little longer to think about. Most people take about 40 minutes to go through the test.
Okay.
So, but that's usually a pretty, I've been setting it at 50 minutes for a long time. Anything longer than that, you start second guessing yourself and start going back and forth.
Okay.
So, but 15 minutes is, because you'd be surprised how quickly you blast through a lot of questions early. So,
Are your questions more like multiple choice, short answer?
well, they're all multiple
All
choice.
multiple choice?
Yeah.
Okay.
So
So no like matching or anything like that?
no matching, all multiple choice, so yeah, I don't like matching. I don't like diagram. Well, diagrams, even if I have a diagram, it would have it'd still be a multiple choice question with a diagram. So, okay. Okay. Any questions from anybody? Okay, then I'm going to get us out of here.